Hi, I'm Daniel Nyman. On behalf of the Forum for Healthcare Strategists, as well as our colleagues at Definitive Healthcare, welcome and thank you for joining us for today's webinar. We are looking forward to a timely discussion on Beyond the Noise, where claims data science meets interpretation. Effectively harnessing data's potential requires overcoming challenges around data accuracy, completeness, and interpretation. Today, we'll dive into the universal roadblocks all healthcare organizations face when working with provider location and claims data. Our speakers will examine the causes of common data challenges and how to work through them to maximize your organization's investment. A couple of notes before we begin. First, attendees are in listen-only mode, but if you would like to ask a question, you can. Just enter it into the question and answer pane located on the bottom of your screen at any time. Our speakers will respond to as many questions as they can in the time we have. Second, we will be conducting an audience poll during the program, so please be sure to participate when that pops up on your screen. With that, I'll turn the program over to Emilio Ruocco, VP Provider and Market Solutions, Definitive Healthcare, who will be leading today's discussion. Emilio?
Hello, everyone. Thank you for joining today, and especially those of you who are joining live. I know that many times people sign up for webinars because they're interested in the topic, but they don't actually join the live webinar. So for those of you who did, extra special kudos, and we're happy to have you and look forward to the conversation. As Daniel mentioned, I'm Emilio Ruocco. I'm the Vice President of Provider and Market Solutions for Definitive Healthcare. I've been in this space for a long time. I'm going to let Leah and Brandon introduce themselves as well. But just a couple of quick things. As noted, I've been in this space for over a decade, and I think there are two important things to know about me. One is I'm not a clinician, but I've learned a lot about service lines, sub-service lines, individual codes, and such. And so hopefully I'm credible as I speak to you today. And so I have a little bit of imposter syndrome, but I do love the space. Secondly, for those of you who've been in this space for a while like me or have used some market intelligence solutions and claims data, you probably have some PTSD like I do from some of the quirks and challenges that we're going to talk about today. So I think it's a timely topic, and with AI coming to the forefront, people want to know, is this ever going to get better? So happy to be with you today, and Leah, I'll let you go next.
Sure. I come from a hospital and health system background. I spent almost 20 years on the health system side before joining the vendor side. And really, my passion is as a consumer of claims and consumer analytics for most of my career. I am really impassioned about building the solutions that I always wanted in that strategy and operations space. Brandon?
Thanks, Leah. I've spent my entire career in healthcare, in both leadership roles in the finance function, more recently in strategy, and specifically in strategic intelligence. So like Emilio, I'm not a clinician, nor am I a data scientist, but I am somebody who really kind of gets a kick out of and hopefully thrives in that last mile space between raw data and actionable intelligence.
Great. All right, let's dive right in. The topic of today is that claims data analytics is still challenging. And, I think the fact that you guys joined this webinar indicates that perhaps you do still find it to be challenging. There are idiosyncrasies that we're going to talk about, and that if you are not yet aware about them, then hopefully this is partially educational for you. And I mentioned up front when I introduced myself, artificial intelligence is the buzzword of the day. Brandon mentioned that he's not a data scientist. I'm not a data scientist, neither is Leah, but we do at our organization employ data scientists. And in fact, some hospitals and health systems are starting to bring them on board as well, because there is so much potential about what can be done with healthcare data. So we'll talk a little bit about the impact of artificial intelligence. And this question is kind of, intended to be provocative, because the answer is, when it comes to claims data-based market intelligence, the answer is no. We can't fix everything. We can do some things, but not everything. So we're going to dive in, and before that, I'm going to ask Daniel to run a little poll with the folks who are in attendance, because it really is topically relevant. So if you take a moment to answer the poll, we'd appreciate it. All right. Data availability in my market. Okay. Noisy, incomplete, or inaccurate data. That's the topic of today. And the complexity of the market intelligence tools. So I think that aligns with what our expectations were, and let's hit the topics right on their head. So I think that actually very interesting that the poll answered this question. I think all of you understand now that data availability has improved. So if you don't know yet, you should be able, in any of these market intelligence tools, be able to get 100% of traditional Medicare data. That means the beneficiaries who have not chosen to take on a Medicare Advantage plan, whereby then they get managed by the commercial insurers who offer the Medicare Advantage plans. On the commercial and other types of data side, you still cannot get 100%, but you can get a lot more than what there was even a decade ago when I started in this space. We're going to cover a couple of topics of why you can't get 100% of the data. So the first thing is there are national, regional, and local factors that we want to tell you about. If some of this is repeated for folks who have dived into this deeply, apologies, but we wanted to make sure that we covered off on the big topics here. Big topics: Medicaid, you can't get 100% of it. And then, for those who've been in the space for a while, you know that Anthem, Blue Cross Blue Shield, one of the big Blue Cross Blue Shield organizations, active in several states and dominant in several states, they try to suppress their data from entering into this commercial claims data analytics space. We can get some Anthem data, but sometimes you lose the chain of the patient as they go to other entities or larger entities. So then I want to talk about the regional gaps. So again, some people may know this, but Kaiser Permanente was one of the first closed loop systems, and their data doesn't flow through the traditional clearinghouses and consolidators that businesses like Definitive Healthcare can source data from. And over time, there can be more of these types of closed loop health plans, one of them being UPMC in Western Pennsylvania, Select Health in Utah, part of Intermountain. And then there are also just regional vagaries that you might experience, like Regions Blue Cross Blue Shield in the Pacific Northwest and some of the West. In some markets, we just don't seem to get a lot of their data. And there's not a lot of rhyme or reason to it. There are many, many different switch points where a claim may hit a vendor. They all have to be HIPAA compliant, and they continue to route the data that ultimately gets to the payer for adjudication. And it's just the nature of the beast. The other thing to know is that there are structural things. And what we mean by here is that there are some revenue cycle management tools and billing applications whose data is not available. The one on the left, you may or may not have heard of, is Availity, which is actually owned by Elevance, the new branded organization for Anthem. And their claims do not flow at all through the claims clearinghouse consolidators. Separately, there is a often hospital inpatient or institutional claim-based entity called SSI that some hospitals use for routing their claims, and their data has historically not been available either. And what this does is it creates, for maybe over dramatizing, but it creates a patchwork of claims data in any state, in any region, in any locality, and actually knowing what percentage of data you have for any given state, region, or locality can be difficult because the impacts are variable. So starting on the right here, just over time, I've come to know that Availity has a pretty good footprint in North Carolina, and there are some ambulatory facilities. We encountered recently a radiology entity for which we had all their Medicare data because we get it directly from Medicare, but we don't have any of their all-payer data. If you look at the UPMC health plan, that actually has a regional effect, which is in Western Pennsylvania, the coverage is going to be weaker than in Eastern Pennsylvania. And as UPMC expands its footprint in Pennsylvania and possibly elsewhere, that might impact the density of data that's available. And then In other states like Utah, where both Regents and Select Health, or in Colorado, where Kaiser and Anthem are both present, you see the impacts that happen there. And so we caution organizations from listening to any claim that there is a percentage of coverage. We use a metric at Definitive Healthcare that basically looks at, in our database, how many unique patients do we have and what's the census? And we hope and believe that for the most part, we have a good longitudinal history for that patient, and that the data is dense and consistent enough from which to make directional decisions. So, final point on this, it's important to know that these circumstances exist before you do any market analysis. I believe most of you on this call probably are aware of that, but we wanted to make sure that we covered on this topic. And so our first recommendation coming out of this this webinar is, know the data that you're getting is going to be incomplete, but it still has directional insights, especially for areas where data has not typically been available. And that includes the ambulatory and outpatient information that state hospital data and state reporting typically don't do a great job of accumulating. And now that we've covered kind of that macro topic of claims data availability, we want to cover off on some of the data quirks that we see in the raw claims data we get. Because, you know, my history with vendors, Leah's history vetting vendors, Brandon's history vetting vendors is always, why can't the data be better? Why isn't it more accurate? So we're going to talk about several topics today. NPES, which provides the NPI1s, which are the identifiers for individuals, the clinicians, and NPI2s, which are the identifiers for locations or organizations. We're going to talk about location naming, types of locations, master billing, payer types, because payer data is important for everyone, specialties of individuals, and then why sometimes in these solutions you see null or redacted information. I want to make one quick note here that we are identifying some specific entities in this presentation. In no way is it to call out their practices. These are endemic situations in the industry, and you know, we just wanted to give you some good representative examples. So, topic number one: why would an individual clinician be listed as the location for delivering radiation therapy? As you can see here in the upper right, in one of our visualizations here, we see a whole host of clinicians that are listed as the service location. And you see them also listed as the performing provider. Well, the fact of the matter is that in raw claims data, sometimes we get an NPI1 identifying the individual in the field that we expect to have an NPI2 identifying the location or the billing entity. And the important thing here is this happens. It happens actually not so infrequently. But you can't just assume that the data is associated with one facility versus another. So here we see for this doctor, Glenn Gazerman, that there are multiple facilities or locations, but the top one is his name. And based on looking at underlying data, there's more than one billing entity that is sending information with his name as the location. So the important thing here is to learn to adapt to these situations. In this case, this doctor appears to be part of a regional cancer care entity. And really the question is Summit Medical Group, which we are probably, many of us familiar with Summit Medical Group, you know, rolling up practices and becoming part of a super group. Are they billing on behalf of him, and are they just listing their own NPI2, or are they billing on behalf of him for several of these locations? So is it Summit Medical Group, or is it multiple locations here? In this case, it's important that the underlying data retains the billing NPI2, the facility NPI2, or the service NPI2, so that if you need to do this type of triangulation and investigation, you have all the data you need to make an informed assumption. I just want to conclude this particular topic by saying that the reverse can also be true. So in this case, we have locations in the bottom left showing up as some of the top providers for angiography and venography procedures. So this can happen in both ways, and we really have to just learn how to adapt to them, because we know the activity took place. This is considered by some to be bad data, but we don't want to strip the data out because it's relevant volume. We don't want to take away, over 1,000 angiography and venography procedures just because it doesn't accurately show who the rendering clinician was. So, next topic. Can a physician assistant or a dentist perform a knee replacement? Intuitively, you're going to say no. The claims data says it's possible. So here's an example for knee arthroplasty, where we have a number of these arthroplasties being performed supposedly by physicians of specialties that don't make sense. Physician assistants who are non-surgical, and all the way at the bottom, dentists and specifically orthodontic specialists. Now, intrinsically, you could say, I understand why this mistake might have happened. Someone might have looked up the specialty taxonomy, ortho, and then grabbed the wrong taxonomy. But it happens, and it comes in claims data. There is a data field on a claim where a provider specialty can be input, and it can have unexpected information. And really, the natural question when you think about this is, well, if you know that an orthopedic surgery can't be done by a dentist, why do you pass this information across? And you'll see that I have a summary slide that says sometimes the claim is more correct than the registration of the clinician. So we don't want to make a blanket black and white decision and say, strip out what's on the claim, only take the primary specialty. So here you see that this is an orthopedic surgeon, this Dr. Vanazzi. He's performing knee arthroplasty at Penn Princeton Medical Center. And, like I said, sometimes the claim is more right than their specialty. So ultimately, because this is variable, you can see at that Penn Medicine location, there are several different specialties represented. You would hope that orthopedic surgery would be the top. Clearly in their billing, they haven't found out that they're making a mistake because they get billed and they bill and they get remitted. And really where this comes down to is when you're working in a market intelligence solution, if you start an investigation with the specialty of the provider, you may miss some real volumes. And this happens variably in different service lines, sub-service lines, and specialties. And so you'll see, we recommend that you study your market and understand what's happening. So second recommendation, start your analysis with specific procedures or service lines before you apply any specialty filters, because you don't want to miss out on volumes. Next topic, master billing. If you don't know what master billing is, it means everything that's happening for a variety of individuals or locations comes out of one NPI-2. And an example of this is in New Jersey, University Radiology Group, one of the largest radiology groups in the state. And frankly, they have, 21 plus locations, 2.1 million procedures done per year. And they have co-locations in several hospitals. And so if you look at this, you say, all right, I want to see the detail on every one of their locations. Well, the overall data is pretty good. We've got 2 million procedures. They said they do 2.1 million procedures, but it's all coming out of one radiology group or one NPI. And so you don't see the distinct locations. Now, the good news is that behind the scenes, sometimes the claims data has sublocation detail. But as you can see, it can be inconsistent. The vast majority is coming out of that main NPI and the main zip code where it's registered. And down below, I show you how some zip codes are represented, but you see variability in the amount of data from those locations. So does that mean that the location is slowing down, or does that mean there was a change in the data in the business practice? And importantly, the reverse can be true. You could see one NPI-2 that is used for a huge variety of locations. And in this case, Sanford Medical Center has a core NPI-2, but 53 different DBA names, which represents the activity happening at many of their different locations and their footprint where they operate. So I wanted to pause here for a moment and say, Brandon, we know that you have a very large market that you operate in with UCLA Health in the LA area. Have you seen this either systemically or locally with either your own facilities, which is one of the learnings that you need to do kind of starting out, as well as with your competitor facilities as you've started to use this kind of market intelligence data?
Yeah, Emilio, it's a great point you raise, and it is an issue, to be frank. Even kind of within our four walls at UCLA Health, we do practice the master billing, and so as a intelligence guy, I could go to my CFO and try to change the billing practice, or I can kind of understand that it's a reality that I need to work within. And I think that generally speaking, you know, I spend most of my time looking outward to the to our external market, if you will. We've got rich, complete data to help me understand our internal performance a little bit better. And so I think that a guiding principle that I've adopted in my time learning to use claims data is to essentially not let perfect be the enemy of good enough, and just to go into this experience with eyes wide open and look for instances that may or may not kind of pass the smell test, and when they don't, look a little further, or at least try to acknowledge them.
And Leah, is there anything that we can do from a systemic or programmatic way to try to address some of these situations? Is this something that you look at from a product standpoint?
Yeah, and actually, this relates to a question we just got into, a question relating to the specialty side. So I'm going to read that question real quick and then try to answer both what you're saying and this question is saying. So Emilio is saying that the claim can be more right. So the specialty of the physician, according to NPES, is wrong. Or is he saying that the provider in the claim is just listed incorrectly because someone on the billing side is inputting something incorrectly? And the answer is both and, right? That both situations happen, which is why it's really important that we don't, when we're building these claims analytics products for you to consume, for you to use in your market studies and your market analysis, it's really important that we don't over-index one way or the other. We actually spend a lot of time building out logic and testing logic that says we're going to pull from the claim first, and then when that's not available or when we think something is off, we're going to pull from NPES. And, as part of definitive and as part of us having a better primary research reference and affiliation data, we have yet another thing that we can enrich NPES with to pull forward the best and available reference and affiliation data, knowing that what Brandon said is so true, even within a hospital and health system. And I've been part of many, how the NPIs are structured. It's largely a legal and billing thing, right? And we struggle with it, even on the health system side. So what we really try to do is make sense to the best of our ability, but not infer or overly assume, but rather to show you where there might be some claim billing practices that can help you understand the market dynamics of how different systems are billing.
Yeah, I guess one final thing that I'd ask Brandon is, I believe, just from my experience, that it's really great to have a visual reference of all the data that then you can whittle down and you can see these idiosyncrasies. And, I don't know if you share that belief, or would you rather just have the data accessible in an Excel file or in rows of data? Does it help you to have the information visualized?
It does. It does a great job with that. I think a lot of other, platforms out there do. I might admit to being a bit of a dinosaur. For a couple of reasons, I like to prepare my final content or presentation kind of on my own, based on underlying data that we get from Populi and Definitive. So, and I think part of that, is my audience. If I'm honest with myself, my audience, sometimes they're physicians. I think we all might appreciate or agree that physicians can get tripped up in the details sometimes, right? And so I feel like it's important that I kind of aggregate or synthesize the details, the data, the underlying data, in a way that is going to be aligned and consistent with the message that that we're talking about, and one that the physicians can, feel good about and agree with.
Yeah, that's a great point. I think you mentioned it up front. These tools are used for discovery, finding insights, and very often the last mile of packaging is done off platform, because the data that drives the visualization can be many, many, many fields, but there are only a few that are interesting or necessary for the final packaging. So your approach is not uncommon. I wouldn't call you a dinosaur, but we're just trying to facilitate that.
Hey, Emilio, there's one more quick question in the kind of chat. I appreciate the open and transparent discussion of the discrepancies on open claims data. Do you think that closed claims is more accurate to understand the market? That's a really good question.
I would actually answer that two different ways. I would say that the Medicare data that you can get from CMS, actually, when we juxtapose it side by side with the open all payer data, is fantastic. It's much, much cleaner. I think CMS just has a higher level of scrutiny to, reject or accept a claim. Closed payer data depends on the source. If you are able to source directly from the payer, you may get very clean detail, but there are also aggregators of single payer type claims, and they often have less detail in the claim than what you get in the raw all payer claim. So it depends ultimately on the source of the closed data, the fully adjudicated, et cetera, and the vendor that you're getting it from. Directly from the payer, if they were willing to play ball, that's great, but some of the single payer aggregators have a little bit less detail in them. So I hope that answers the question. So kind of continuing this topic, so we talked about, some of the anomalies of NPI 1s and NPI 2s. Well, the next thing is, when is a location, and is the name correct? And do I understand where that activity is actually taking place? So, NPES is only as good as the information that is registered within it. And Leah talked about how providers may not even update their specialty, or they may have mismarked what their primary specialty is. And so you can have anomalous situations. Same thing can happen with locations, kind of on a different level. First of all, we talked about the NPI 1s and 2s and master billing. In this case, it looks good. This, McLaren Health in Michigan looks to have specific NPI 2s for specific hospital locations. Conversely, University of Michigan has many NPI 2s, but many of them are registered for the same address. So is there one that's more important? Do you need to roll up the information? If you roll it up and then subsequently have to disaggregate it for whatever reason, because you find that there is a sub-location where you want to actually isolate activity, how do you address all of that? So in this case, we keep the pure NPI 2 that comes on the claim, and we let our clients, figure out with their local market knowledge, what the relevance is of the data and whether they want to roll it up, if not, in that final packaging that Brandon spoke about. And, I called out McLaren as doing a good job, but unfortunately, they've got 9 different NPIs just for their Central Michigan location and several other NPIs for others. So when entities try to do a good job, sometimes they register the same DBA name under many different NPI 2s, and it creates just as much of confusion. The other thing that can be confusing is location types. So a clear example here, different location. We're in Texas now. This is Christus Mother Frances Hospital in Tyler, Texas. They are a general acute care hospital. That is how they are registered. Unfortunately, this hospital has a personality disorder, because from time to time, they think that they are an ambulatory surgery center. They think they're a family medicine specialty. They think they're a multi-specialty clinic. They even think they're nurse practitioners, and they don't know whether they're a critical access hospital or a general acute care hospital. This is a similar situation to what we noted before around provider specialties. Claims have a entity specialty that is listed on the claim, and that can be in conflict with what you or I or other end users know the facility to be. And so it's important to know that, again, that earlier advice of pick what you want to look at before you pick the who or the type of clinician that you want to look at. Same thing applies to facilities here. And even knowing where a provider performs their activity can be difficult. So we've talked about entities, individual providers, kind of in that juxtaposition of NPI 1s and 2s, but we're going to walk you through a very clear example. So this is a clinician in Brandon's kind of extended market. They are a urologist, and that information seems clear. And based on the data, it looks like she has activity attributed at 8 different service locations. Now, the number 1 location is called Lamia El Gabal MD Inc. Now, one thing to notice in claims data is that the clinician will have an NPI 2, and sometimes single individually run practices will simply take their name, slap an LLC or an Inc. At the end of it, and register it as the NPI 2. So the interesting thing here is we're talking about Dr. Vera Trofimenko, but her main location is this North Tustin Avenue suite in Santa Ana, California, tied to this clinician, Lamia Gabal. So follow me here. Vera Trofimenko, their primary practice address is listed as that North Tustin suite, 104 in Santa Ana. However, if you do a Google search and you search for her, you'll find that she practices at a location called Prestige Medical Group. And there is no NPI 2 for Prestige Medical Group, not even anything in that state of California. Now, the providers, in this case, Lamia Gabal MD Inc., that location is at 720 North Tustin Avenue. There's a slight difference in the suite number. Dr. Trofimenko was at suite 104. This shows suite 140. Could be typo, could be transposition or whatever. We see that on the website of Prestige Medical Group, Dr. Gabal is there. She probably founded it, but maybe the group or the practice expanded. Unfortunately, when you look at that particular website, the address is completely different. It's at 18302 Irvine Boulevard, Suite 200 in Tustin. So we're in the generally right location. We're looking at raw data that might say something incorrect. We're looking at web data that says something that might be more current. So this is confusing. And really, ultimately, no directory can be perfect. So when we translate NPI 1s and 2s, we do our best to try to translate the information. But frankly, this topic of provider directories could be a whole separate webinar. The one thing you can do is that depending on, the mechanisms that your vendor uses, to provide you a market intelligence solution, you should have the ability to change information as you want. So in this case, we can take the location that is indicated as Lamia Gabal Inc. and change the name to Prestige Medical Group. So that's what we're showing you here in a little interface that shows how you can manually change this information. And then the data can show up in a more clean fashion. Now, the address information may not be perfect and things like that, but at least here, for the local market knowledge, the Prestige Medical Group can show up. And those changes that I just showed you that can be made in that interface, they show up in this platform in 15 minutes. So very timely. So I'm just showing you, with the permission of Brandon, a couple of screens of what UCLA Health has been doing, both on the location level, changing the names or aggregating locations to a more mastered alias name, as well as looking at providers and flagging them, whether it's a location or an individual clinician. And really what I wanted to ask Brandon, you have a very large organization, and I just want to know, what some of the process was that you did to really get to essentially close to a master list of your affiliated or employed or faculty clinicians, and understanding your locations and making sure they're named correctly. And, really, is the juice worth the squeeze, given that that the underlying data may be a little bit noisy?
That's a good question. I joined UCLA Health about a year ago, and one of the first actions I took was to kind of get my arms around where we stood with our data intelligence setup. And as I got to learn about our involvement with Populi and how we were using the tool, it became clear to me that it was probably a very high yield opportunity for us to spend some time, invest some time with getting kind of these mappings right. And so I got to know the folks in credentialing. We created, a crosswalk, if you will, and we got, I think, pretty darn close to being accurate enough that we're comfortable with it. I'll be frank, it's been probably a year, and I think that it feels about the right time to kind of go through that process again. It's never going to be perfect, but I think as soon as we accept that and understand it, then we can really kind of rise above the noise and still hear the signal, if you will.
Well, I appreciate that perspective. And, it's cliche to say, don't let perfect be the enemy of good. But, if you can get to 80% accuracy and clarity, it's better than starting with what we get from scratch from the claims data. So that really kind of gives us our third recommendation, which is local market knowledge always needs to supplement claims data. And, hopefully you have the ability to incorporate your local market knowledge into your tools so that you can aggregate. And sometimes when that breaks down a little bit, or there's things that are insurmountable, you kind of have to bring your analysis up a level and make it a little bit more broad, because sometimes the detail falls down when we get into some of those vagaries that we see in the data.
We do have a few questions coming in that I think we could just take a minute to address.
Sure.
For Brandon, do you want to talk through just any best practices you have for consolidating NPIs for your competitors in your market?
Oh, wow. Good question. I have a practice. I probably would hesitate to call it a best practice, but I look to Populi to kind of give me the data in its raw form, and then we definitely add the human element to it, right? Because I think in order for you to get to the point where it's accurate, actionable intelligence, right? You need to scrub it a bit. So whether that means doing work outside of Populi in Excel, I probably spend more time, and my team does, in doing Google searches, or Doximity can sometimes be a good kind of confirmation or path to take. LinkedIn, I probably seem to be a lurker to a lot of physicians in the Los Angeles market. Our team, we look at LinkedIn. I don't think that there's any silver bullet here, but it is an issue, and I'll acknowledge it. And it's one that we definitely try to address. And I think at the end of the day, what we've been able to produce based on data that we're getting from the claims activity is, I think it's serving our organization well. It just takes that last kind of little human element to make it ready for prime time.
Very good. Leah, other questions?
Yeah, Brandon, just one more question. As a user of these data solutions, how do you get your audiences to trust and act on your market analyses given the issues we've been talking?
Yeah. Well, I anticipate that there's going to be skepticism and hesitation. And so one practice I've adopted is to kind of disarm those concerns, or at least help to put people at ease from the beginning by giving, the 30-second elevator speech about how we're dealing with claims data. It's not perfect, but I think that there's accurate intelligence that we can glean from it if we're willing to accept that it's not perfect. And I think in time, I kind of made jokes about how physicians can get tripped up in the weeds. I believe that to be true. I think if you're talking to C-suite folks or your chief strategy officer, they're probably going to be a little bit more willing to kind of walk with you and to accept the data. And so you fine tune your message accordingly.
Yeah, and I would just add on, I had the opportunity to work with a really sharp group of neurologists and neurosurgeons, and they would sometimes ask the toughest questions over the C-suite. And Emilio, I just kind of tag on because we briefly touched on state hospital data. So I've worked with state data in my career for probably 8 or 9 states. And I would say the other thing is that the claims data is a both and strategy with state hospital data. There's timeliness factors where you get claims data a little bit more depending on what state you're working with. You may not actually get all of inpatient or even all of hospital outpatient. And so it's really about forming that strategy of putting the appropriate data sets together. And I'll give you a really good example for a regional health system that I worked for 6 years. We could not figure out why we showed as #1 in chemotherapy when we had an academic medical center in our mix, and we knew that their cancer center was #1 in the market. And when we got claims data, we realized they weren't billing under the hospital outpatient umbrella, so they weren't submitting it to the state. They were actually billing under their physician practices. So that's another really good example of how you put these market data sets together to kind of tell the complete picture.
Yeah, great. Great to know. We only have 2 more topics left, redacted and nulls and the dreaded payer information. So let's talk about redacted and nulls, and I may call on you again, Leah, to talk about this. As you can see in the screenshot that I'm showing you here, there's redacted information in the service location, and there's redacted information in the performing provider box that we have here. And, and this just simply happens in claims, and it can happen across a range of activity. And I think that it can be a little bit confusing to people, because sometimes if you think about all the little, it's death by 1,000 cuts. If there are 1,000 entities that have some redacted information, then the term redacted aggregates to be looking like, oh my God, we have so much redacted information in the market, when actually it represents, 2, 3, 8% perhaps of what's in the market. So there are a couple of circumstances under which data is redacted. Sometimes it's just missing data on the claim, because I think, Leah, you can talk a bit about how claims don't always have to have every field filled in. But there are also some different areas where it can happen that relate to PHI. So I'll let you expand a little bit upon that.
Yeah, there's really a couple of situations where we see some redacted or null values. And again, it's really important for us that we don't overly infer, because we don't want to get something wrong and then have you have an insight that's completely off base. We see a lot of redacted and null MPIs on things like DME and even physical therapy, and sometimes where there's not like an NPI, or it's not very clear, or it's not an individual, providing that care. So that's one time. You can also see a null and a redacted situation happening in some of the clinical service lines. And we try to keep our pulse on monitoring the percent of time that the null values come in. I will note, and one thing we're keeping our pulse on is, as things like the GDPR and the privacy rules that each state are kind of enacting. There was a situation a couple years ago now where California determined that an NPI was a PII element. And clearinghouses started to pull back and redact and null out the NPI level information. Luckily, that was kind of reversed, and now we're seeing those fill rates come back again. But as we go through this privacy policy regulatory space, that is something to watch and be aware of, that we are trying to protect certain classes of information, and it might lead to a few more redacteds, in the future.
Well, and I would add to that, Leah, that, that circumstance that we happened to observe, a couple of years ago, that dramatically can impact longitudinal analyses. So you got to make sure that behind the scenes you have the tools and the partner that can research and find those anomalies, because if you're doing research and you find a strange dip or a market share that doesn't seem to align with what you believe the situation is, we have to be able to go upstream and look at what the root cause is. And that happened to be, as Leah mentioned, a temporary situation. So let's go now to the last topic, payer information. So payer information is a kaleidoscope. That, I would say, is putting it politely. If I was a little bit less polite, I would say it's an unholy mess. So here's what we would all like to see in raw claims data: a payer ID that is consistent across the country, a payer name that is consistent across the country, and a clear and accurate indicator based on the claim type and payer type ID that's on the raw claim that says something belongs to Medicare Advantage or Medicare Supplemental, commercial, Medicare itself, etc. This is what we'd like to see. Unfortunately, this is what we actually get. We get 24 plus different kinds of payer names. We have the ID that is not always an ID. Somehow it's getting processed. You've got type of coverage that runs the range from commercial to even Blue Cross Blue Shield, when everyone knows that AARP Medicare Advantage is run by United Healthcare. And so literally there's only one line here that is uncontroversially correct. All the others would require some type of correction, either through data science or some other mapping logic. And what I'm not even showing you is the fact that some of this data comes across with patients from 0 to 18, or from 19 to 45 or 64, people who are not covered by Medicare Advantage plans. So unfortunately, this is the nature of the beast. It's one of the things that Leah and I and other data scientists that are at Definitive, we talk about quite often, how to systemically fix this. And really that kind of leads me to my final point, which is you have to research your and your competitors' data up front to understand the quirks that are present in your market. I'm not going to call out different states or different submarkets as being better than others. There's different coverage levels, as we talked about, but these kind of endemic, quirky situations occur in every market, and you just need to learn them up front. I think, Brandon, you said it well, that the juice is worth the squeeze. But it's something to study before you just dive headlong into a solution and say, I'm going to present this data because my vendor told me that it's right. And I guess I pose this question to Leah, just from your background and as the head of product for our organization: why can't it all be better?
Well, I think we should all advocate for more standards in billing practices. Medicare fee-for-service data is some of the cleanest data that you will see and encounter, and that's partially why we keep that part of our claims analytics separate, so that you can see a really, really clean view. It doesn't help like children's hospitals and when you have pediatric offerings. So, we still have to do quite a bit of work on the all-payer side. I've worked with a lot of different solutions over the years, some that really took a heavy hand with creating inferences and market estimations and all of that. And what I've found is a more pure view, so that I can actually see and make my own judgments about what's happening in the market, is really highly valuable. And we did get a question that I'm hoping, Brandon, maybe you can help, and Emilio, and I think that might round out this question too. We've recently experienced several health systems changing the clearinghouses they're billing through, which is creating higher volatility within the volumes. It's really brought some of our analyses to a halt. How do you deal with that? What work can we do to kind of work through that?
So I guess I'll take the first stab at it. There's actually kind of two situations that are interesting that you need to be vigilant of. One is, with some of the hospital consolidations and health system consolidations that are happening, in some cases, they will actually re-register an NPI with a new naming convention. And in some of the historical claims data, you want to see the history of the individual facility and then as the combined entity going forward, and that can be a situation. The clearinghouse changing situation should not dramatically affect your volumes unless that entity switches from a clearinghouse that is in the normal, pretty commonly available data feeds to a clearinghouse or a billing system that somehow does not feed through these clearinghouses and consolidators. So most often it's going to be either a switch to Availity or SSI, which are kind of the two commonly known ones. But unfortunately, there's like 1,800 different revenue cycle management tools and billing systems, and the consolidators and the clearinghouses they may not get every single feed. And equally important, unknown to all of us, are sometimes there are specific data use rights. So the clearinghouse may not actually have the right to sell data for a particular tool or billing system. So, the challenge is finding out what are all those individual, blockages, if you will. And unfortunately, there's not a systemic way to do that. And, I don't know, Brandon, if you've observed this in your market as well, that changes in billing entity and sort of drop-offs, cliffs, and initial rises of new entrants supposedly in the market, but it turns out to be the same facility.
Yeah, I don't know if I could attribute it to any one particular reason, but I have observed what I would maybe characterize as lumpiness in the data, and so I would love to work with data that's nice and homogeneous and feels clean and consistent. Almost all the time, that's my experience. Sometimes though, and there was one case where the data looked lumpy, to use that term, right? And so you kind of step back, you maybe aggregate up to a higher overview type level to try to make sense of it. But I probably sound like a broken record, but at the end of the day, you just want to be aware, go into it with eyes wide open, and be transparent to your audience and with your team where you might have concerns with the data, call it out.
Very good. Well, I think, Leah touched on this as she started her answer. Without a mandate for all of it to be better, we're not going to get there. And I don't know if any of you on the call today have experience with the price transparency data that was mandated to be released, and it's an equally unholy mess to the payer information that I cited. And hopefully that will get better. Topics that we talked about today will get better. With that, final thoughts, what are our summary recommendations? We'll give this all to you. We covered them individually about understanding what's going on in your market, studying your competitors, making sure that your knowledge in some way, shape, or form can be incorporated into your market intelligence solution. And, really important to start with the what are you looking for, not the who necessarily. Find out the who after the fact. Those are kind of 4 kind of macro topics that we wanted, or recommendations that we wanted to give you. And, we hope that AI can help some of these things over time. We're studying it. We're applying it with our data science team right now. But we don't have silver bullets for you that are going to solve all these issues right away. With that, I think we're give a few minutes of time left. Really want to thank all of you for attending. As I mentioned, we always appreciate those who attend live and in person. I hope you found the content useful and can share it throughout your organization once the forum sends the information out to you. And feel free to contact any of us with specific questions that maybe were not answered today. And I want to thank, Leah in her role. She knows that I press her often and deeply on how to fix some of these things, and we collaborate very well together. Brandon, I want to thank you for sharing some of your perspectives as a, I would call a power user of this data. You have always asked us really, really topically appropriate questions and probed, and so we thought it would be great to have you on the call today. So thank you for joining us.
Thank you all for those insights. I'm sure the audience joins me in thanking Brandon, Emilio, and Leah for that awesome presentation. And to all of you in the audience, thank you for taking the time to join us today. Please note that if you've asked a question that we weren't able to get to, we'll do our best to get a response to you. We'll also be sending out a link to the webinar recording, so watch for that in the next few days. Finally, be sure to give us your feedback by completing the evaluation survey as they exit the webinar. We look forward to seeing you at future webinars, as well as the 30th Healthcare Marketing and Physician Strategy Summit in Orlando, April 30th to May 2nd, 2025. If you're interested in speaking, the call for speakers is now open. You can find that on the forum website at healthcarestrategy.com. That concludes today's program. Thank you and have a great day.